Bismillahirrahmanirrahim. Now we'll discuss the second half of our hemorrhage topic, which is postpartum hemorrhage. Postpartum hemorrhage is the bleeding that occurs after delivery. Now it is divided into various classifications. The first two we'll study is primary postpartum hemorrhage and secondary postpartum hemorrhage. Primary indicating the blood loss more than 500 ml within the 24 hours after delivery. This is classically seen in uterine atony. Now, this is a condition in which there is no contraction after the placenta has been delivered, because there is a great confluence of uterine arteries that are previously supplying the placenta. So whenever the uterus will not contract after the placenta has been delivered, there will be hemorrhage, which will result in anemia, tachycardia of the mother, and even can lead to shock. And secondary condition, this basic classification is time dependent. So in secondary, there is increased loss of blood loss more than 500 ml, but the period is between 24 hours to up to 12 weeks. Now this is classically seen in conditions like retained product of conception. Whenever the cotyledons of the placenta is still left in the uterus, this would result in a later large amount of bleeding. Now our second classification is minor bleed and severe bleed. In minor bleed, the bleeding percentage is up to from 500 ml to 1000 ml, whereas in severe bleed, the blood volume is more than 1000 ml. Now, those are the risk factors that can result to such a condition, and the pre-existing ones are the maternal age. That if the age is less, there will be more causes, or if the age is more than 45, this can lead to PPH. And if the mother is first time pregnant, or in case of uterine fibroids, because during pregnancy there is a condition that fibroids become very vascular and active, such as known as a red fibroid, so the bleeding tendency increases. And this can also be seen in previous C-sections, obesity. I don't know how it affects it, but it's a risk factor. Then, in fetal causes, macrosomia. Macrosomia is commonly seen in diabetic mothers, with the fetal size is very huge. So that is known as macrosomia. Multiparity and is an obvious cause of postpartum hemorrhage, as well as shoulder dystocia because of trauma that is related to the uterus while delivering such a baby. And intrapartum, such as prolonged stages of labor, which can be either second or the third. Second, in which the baby is actively delivered by maternal contraction, and third, when whereas placenta is being delivered. And it can be in it can also occur in C-sections, which is the trauma to the uterus itself, episiotomy, which is the trauma to the outermost foregut of the vagina, and as well as in pyrexia of labor. Pyrexia in labor, which is fever that is accompanied with labor. Now, the most probable or the most important things that you need to determine is postpartum hemorrhage are the 4 T's. The first T indicating the tissue, which is we've previously discussed, retained product of conception, which can lead to postpartum hemorrhage. Then loss of uterine tone, due to which the vessels cannot contract anymore, which can also lead to bleeding. Hence, the next T is for tone. The third T is for trauma, that is elected by episiotomy, C-sections. This can also include trauma to the vagina as well as the perineum. And last is the thrombin. If there is deficiency of the clotting factors, that would result in blood diathesis. Similarly, as long as the clotting profile is imbalanced, such patients will also bleed out. Now, so much bleeding has occurred, so what happens? Anemia is quickly elected. This would result in tachycardia. The mother heart would push because of little amount of blood will contract more. This would result in tachycardia. But as the blood quantity is very less in her system, so this would result in low blood pressure. This would be accompanied with nausea, vomiting, paleness due to anemia, slow capillary refill again due to anemia. And the basic sign, the earliest sign in such patients with lots of hemorrhagic blood coming out of her is tachycardia, and this is commonly seen when the blood loss is more than 1000 ml. Now, in such a patient, what would you do? The first management is resuscitate the patient by ABC protocol, which is maintaining the airway, breathing and circulation. Then we need to summon appropriate staff in order to assist and rule out common problems in order to prevent this from happening further. Now, next is we need to provide adequate amount of oxygen because the patient has become anemic and tachycardic, so her RBCs have become oxygen deficient. And then we need to do clotting studies in order to rule out what is the basic problem. Along that, we do basic studies such as RFTs and LFTs in order to see the erythropoietin ratio, or if there's some other problem that is occurring in the female. We attach IV fluids with her, maintain her electrolyte balance, insert a Foley's catheter, obviously because she cannot move very much, so a Foley's catheter is needed. We need to establish a CVP or arterial line to give her start her on blood transfusion, and if we discover blood diathesis, we give her a frozen plasma and platelets are arranged. Now, after we have discussed or done all of the basic things, we now see that what was the basic cause. So in case of atony, if it is suspected the uterus is not contracting, then how will we overcome such a condition? We want the uterus to contract, so it would stop the dilated blood vessels from bleeding out furthermore. So we do this by giving the patient prostaglandins such as or oxytocins, and the other thing we can do is we can rub it by bimanual palpation. Now, this by rubbing, this would cause the muscles to contract, and similarly contraction when it starts in the uterus, it will be able to stop the bleeding. Now, another thing what we need to do is we need to actively manage the third stage of labor, which is delivering of the placenta. And other causes that can also lead to PPH is retained product of conception. If any part of or any cotyledon of the placenta is retained, we would do dilation and curettage. Now, be mindful of that and not injure the uterus on the way. And if some sort of trauma is caused to the cervix, the vagina or the perineum, we need to immediately repair it. And for coagulation problems, we need to give the patient FFPs and platelets.